Hello everyone, welcome to part 2 of this revision of orthopedics. My name is Dr. Jhanvii. I am the anesthesia educator on Unacademy and I've got a gold medalist in anesthesiology. This is the Telegram channel where we share all our classes and their links. So you can find all the free classes over here and don't forget to join it. The plus subscription on Unacademy will help you get access to both live and recorded classes. You can learn from India's top educators, you can compete in live tests and quizzes, and you can access our question bank with 25,000 plus questions. We now have printed notes for those who buy 12-month and above subscription. There is a partnership between Unacademy and Prep Ladder, which will help you get all the live lectures of Unacademy along with the video lectures of Prep Ladder. And these are our special class features. So if you see on the right hand side, you can speak to me during the class. You can ask your doubts. At the end of this class, you can download the PDF and use the lecture notes for your benefit. We have a question bank which we have introduced with 25,000 plus high-yield clinical questions. There are NEET PG toppers. This is some of the batches that are going on right now. So the clinical case discussions and instruments batch, Target Next Integrated 2023 batch, Target NEET PG 2022 batch. And if you would like to attend any of these batches, you can use my code Dr. Jhanvi Live and get a 10% off on your subscription value. All right. So let's begin with from where we left off. So there are a few questions I want you guys to answer before we start off with the tumors again. Okay. So let me see how many of you all understood what I taught you in the last lecture. So classify this fracture as per the Salter-Harris classification. Type 1, type 2, type 3 or type 4. I'm starting a poll for you guys. Okay, so in the last lecture we saw the Salter-Harris classification. So in that, type 1 is separated growth plate, type 2 is fracture line going above the growth plate, type 3 is fracture line going below the growth plate, and type 4 is fracture line going through and through the growth plate. So this one is fracture line going through and through the growth plate. So this is type 4 Salter-Harris classification, correct? Okay, now this one we already did: osteopetrosis, marble bone deformity, endobones appearance, champion glass deformity, and rubber jersey spine. In this case, identify the bone fractured over here. Simple one. Okay, all of you have answered it correctly, so I'll stop the poll over here only. What will be your treatment for this? What will be the treatment in this case? This is a transverse fracture which has displaced the two parts of the patella. So what will you do? You will do a tension band wiring, correct? Tension band wiring or figure of 8 wiring in that case. Alright. Next question that I have for you guys. A patient will have which nerve injured if he cannot do this sign? Okay, so what is the sign called as? It is called as OK sign. Okay, so what is the nerve that is required to do this OK sign? You have to move your thumb. So you have to adduct your thumb and oppose your thumb. And you have to move the index finger. So the nerve that is required for carrying out this movement is nothing but your median nerve. Okay, and which branch of median nerve supplies this? It is your anterior interosseous nerve, which is a branch of the median nerve. Okay. Now, this nerve is affected in which fracture? After which fracture will the patient have an injury in which he will not be able to do the OK sign? Lunate fracture, no. Scaphoid fracture, no. Okay, so most commonly your anterior interosseous nerve is damaged in fracture supracondylar humerus. Remember, your fracture supracondylar humerus and your fracture neck of femur and Colles fracture. These are the most commonly occurring fractures all over. So whenever they are talking about most common, think about these fractures only, okay? Not the very unfortunate uncommon ones, okay? So here you are going to have weakness of your flexor digitorum profundus and flexor pollicis longus. Pollicis longus is supplying the index finger, okay? So that is why you are having the weakness of this. What is if the patient has radial nerve palsy? Then what is the sign that you will see? In radial nerve palsy, what is the sign that we will see in the patient? Very good, wrist drop. Okay, and suppose I say that my patient was in lithotomy position. All these nerve injuries now they ask very commonly in the exam. So I say my patient was in lithotomy position, and after that my patient is presenting with a foot drop. So what nerve is injured in this case? Yes, very good, Tariq. It is the common peroneal nerve. Okay, common peroneal nerve. Where does it get injured? So this is the medial half of your leg where you have the tibia, and then you have the small bone over your fibula, correct? So at the neck of the fibula here, your common peroneal nerve will go like this, like a circle at the neck of the fibula. And when I fix the leg in lithotomy, my legs are like this now, so lateral part of the leg gets compressed. So as a result of this, my patient will have compression on the lateral part of the fibula, that is the common peroneal nerve causing compression and foot drop, okay? Okay, identify this deformity seen in Pott's spine. So look at the number of vertebrae that are affected over here, and from what I taught you earlier, tell me the name of this deformity. Kyphosis, prolapsus, gibbous or knuckle. Yes, absolutely correct. So as Tariq has mentioned, if one vertebra is affected, it is called as a knuckle. If two vertebrae is affected, it is called as a gibbous. So here you can see two vertebrae affected, this one and this one. Both of these are destroyed. So it is a gibbous. And if more than two vertebrae, if three or more than three vertebrae are involved, it is a kyphus. Many of you all got confused between how many vertebrae are destroyed. Okay. Alright. Identify this fracture. Galeazzi fracture, Monteja fracture, nightstick fracture or Schoffer's fracture. What is the bone that is getting fractured over here and which part of the bone is getting fractured over here? Ulna is getting fractured, very good. And is this proximal or distal part of the ulna? Okay. So this is the distal 1/3 of the ulna that is getting fractured. So this is called as your nightstick fracture. Any idea about Galeazzi fracture, Monteja fracture, Schoffer's fracture? What all happens in that? Okay. So remember Galeazzi and Monteja are both fracture plus dislocation. Okay. One bone will get fractured, so the other bone will get dislocated. So in Galeazzi fracture, you are getting your fracture of the distal 1/3 of the radius and your dislocation of the ulna. Okay. And what will you get in Monteja? Uska ulta. You will have fracture of the what radius had fractured in Galeazzi. So you can remember it as GR. In Galeazzi, you have radius fracture and ulnar dislocation. And in Monteja, what will you have? You will have ulnar fracture and radial head dislocation. Okay. Then nightstick fracture is fracture of the shaft of the ulna. And one more thing that you need to know is your Schoffer's fracture. People who drive, when you drive like this, if you have a little bit of a injury, aisa ulta. Okay. So this can cause your intra-articular fracture of the distal end of the radius. So that is your fracture of the distal end of the radius. Okay. Now, if I have extra articular fracture of the distal end of the radius, then what is that called as? Very famous fracture. Outside the joint, extra articular. This is intra-articular fracture of the distal end of the radius. If I'm driving like this, I can get fracture over here causing Schoffer's fracture. If I'm having Extra-articular fracture, what is that called as? That is my Colles fracture. Okay, Colles fracture, it is your extra-articular fracture of distal end of the radius. Okay, all right. This identify the condition of the spine and in which situation is it seen? Osteoporosis, sickle cell anemia, osteogenesis imperfecta, or all of the above? I taught you both these conditions in the last class, guys. Still, half of you all are marking the answer wrong. More than half of you all are marking the answer wrong. Why? Why like that? Okay, so the answer is all of the above. What is the appearance called as? It is called as cord spine or fish mouth spine. Okay, so in which condition do you see this cord fish appearance of the vertebra? You see it in all of them. In osteoporosis, because you have vertebral collapse. In osteogenesis imperfecta, because you have vertebral collapse. And sickle cell anemia also you see it. Okay, so fish mouth spine or cord fish spine is seen in all of the above. Okay, now one more over here. This condition of the spine is seen in which case? Secondary hyperparathyroidism, osteopetrosis, chronic renal failure, or all of the above. अभी सबको समझ में आ गया. If I'm giving multiple options, then you should directly go for all of the above. Correct? That is a trick to be used. Okay, so we knew that in osteopetrosis you see this appearance, alternate light and dark banding. This is called as rugged jersey appearance, correct? In chronic renal failure, you can just think about it. Your kidneys are responsible for producing a hormone called as parathormone. So if you have renal failure, amount of parathormone will go low. Parathormone maintains the blood calcium levels. So if parathormone levels are low, the blood calcium levels will also be low, and in fact there will be deposition of calcium on the bone. So that is seen in case of chronic renal failure. Okay, even if you can mark answer for two of the options, directly you will know that the answer is all of the above. It's not necessary कि तीनों तुमको पता होना चाहिए. So दो भी पता चल गया तो you will be able to answer them. Okay, all right. The deformity shown in this picture is most commonly seen due to fracture radius, fracture ulna, fracture radius and ulna, fracture humerus. Okay, why only 39% has answered this? What is the name of this deformity? I just discussed with you guys in the last class. Yes, this is Volkmann's ischemic contracture, correct? Remember I told you malunion of the supracondylar fracture of the humerus can lead to Volkmann's ischemic contracture. And it is seen in supracondylar fracture humerus. Clear? Yes. This deformity is seen in which condition? Osteoarthritis, rheumatoid arthritis, gout, or psoriatic arthritis? This I'm actually going to teach it to you guys now. All these bone related arthritic disorders. Yes. So you're seeing the distal interphalanx is moving like a swan neck. Okay, so this is your swan neck deformity. Swan neck deformity that you see in case of rheumatoid arthritis. Any other things you see in rheumatoid arthritis other than swan neck deformity? In the hands, what other deformities are seen? Do you have ulnar deviation of fingers? What is that deformity called as? No, not boutonniere deformity. You have ulnar deviation of the hand. So your hand, sorry, radial deviation of the hand. So your hand looks like this. Z deformity. Okay. So that is called as Z deformity of the hand. Okay. Now, in which condition do you see this deformity? Osteoarthritis, rheumatoid arthritis, gout, or psoriatic arthritis? And tell me the name of this deformity. What is the name of this deformity that you're seeing? Herberton's nodes and Bouchard's nodes. Okay. How do I remember it? I remember it as H, B comes before H. When you do A, B, C, D, E, F, G, H, B comes before H. So B is more proximal and H is more distal. Okay. So you have Bouchard's nodes and Herberton's nodes. So your Bouchard's nodes and Herberton's nodes both of these are seen in osteoarthritis. Clear? Okay. Identify the fracture in this case. Fracture clavicle, fracture first rib, fracture acromion, or fracture spine or scapula. Yes, very good. So all of you can identify over here. You have the medial 2/3 and the lateral 1/3 over here. Fractured. So this is fracture of the clavicle. What is the treatment in fracture of clavicle? Anyone? Yes, very good. You will give the figure of 8 bandage. What is the most common age group in which you get fracture of clavicle? Is it very common in adults? Figure of 8 bandage comes like this, like an 8 in front of your body and you hold it like that, your hand. Is it very common in adults? No, it is common in newborns. So why do you get fracture clavicle in newborn? Why do you get fracture clavicle? So when you're doing instrumental delivery, when you're removing the child out with some kind of instruments like your suction evacuation or forceps delivery, especially during forceps delivery, if you compress on this part of the baby and you pull it out and the neck, and there is a lot of traction between the neck and this arm, then it will cause a breakdown of the clavicle. Okay. So in newborns, you will get this fracture of the clavicle. Yes, in diabetic mother you get it because in diabetic mothers, why? They have a very big baby. Size of the baby is very big. So they have instrumental delivery many a times because it's not easy for the baby to come out vaginally. Okay. So instrumental vaginal delivery you will get fracture of the clavicle. Okay. And the most common site where it is occurring between the medial 2/3 and lateral 1/3. And remember, there is a vessel over here, big vessel called as the subclavian artery. So the subclavian vessels get very commonly involved in that. Okay. This is your figure of 8 bandage. Look at it looks like an 8. That's why. Okay. Identify the condition in this case. Jefferson's fracture, hangman's fracture, degenerative arthritis of spine, or cervical vertebral osteoporosis. It's a little difficult, but we have already discussed these fractures before, so that's why I included this slide. This is C1 fracture, not C2 fracture. Actually, there is a sign over here. Can you try to imagine that this looks like the face of a bulldog? If I show you over here, शायद दिखाई देगा. ये दिख रहा है तुमको bulldog being formed over here? So, and then there is a fracture here in the neck of the bulldog. So this is called as your Scottish dog appearance or Scottish bulldog appearance. of the fracture. Okay, and this is seen in case of Jefferson's fracture, Scottish bulldog appearance. दिख रहा है? थोड़ा difficult है, लेकिन ठीक है, आएगा तो okay. Okay, so all of you all know the vertebra that are involved in these fractures. I did it in the last class. Identify the name of the splint. It's very important. The splint is used in fracture of the femur whenever you want to immobilize the leg and you don't want the person to move the leg. Okay, so Bowler-Braun splint, Kramer-Weyer splint, Dennis-Brown splint, Thomas splint. Okay, very good. So most of you have answered this correctly. This is Thomas splint used in fracture of the femur. Okay, this is your Bowler-Braun splint. Just remember some of these splints and how they look like. So can you see Bowler-Braun splint has pulleys over here? So pulleys where you will put this wire and that wire will fix against the lower end of the femur or the upper end of the tibia and it will hold the leg straight. Okay, and this is your Kramer-Weyer splint. Okay, so this is also used in fracture of the femur. So all these are the different types of splints that are used. Your Thomas splint is the most commonly used one. That's why I put it as a question. Other than that, you can just remember this splints. Okay. Okay. This test indicates injury to which nerve? Axillary nerve, long thoracic nerve, spinal accessory nerve, or ulnar nerve. Yes, very good, Nemisha. Absolutely correct, Tariq. So this is winging of the scapula, correct? The scapula is becoming very, very obvious. So this is winging of the scapula. And this is seen due to injury to long thoracic nerve of bell. What is the root value of long thoracic nerve of bell? Anyone? Root value of long thoracic nerve of bell? Yes, C5, C6, C7. Alright. Identify the disorder in this case. Lumbar spondylosis, pot spine, fracture L1, L2 or osteoporosis of the spine. Okay, so can you see over here what are they trying to show? First of all, which part of the spine is this? Yes, they are trying to show the fish mouth appearance of the spine in this case. The arrows are actually marked very anteriorly, but this is not right. But they are trying to show the small curvature of the spine that is seen in this case. So this is nothing but your fish mouth spine. I know this is not a very good and representative picture of the same. I put better picture of fish mouth spine, so don't worry about that. Alright, so now let's go on to discussing the rest of the cancers and the osteomyelitis and arthritis, correct? Okay, so we were discussing about E-wing sarcoma. So where does E-wing sarcoma mostly arise from? Which part of the bone does it arise from? Does it arise from the periosteum? Does it arise from the medulla? Where does it arise from? Metaphysis, diaphysis, which part is affected the most? Okay, so your E-wings is arising from the medullary cavity. Okay, and it is also called as small round cell tumor. Please remember this. It is also called as small round cell tumor. Okay, what is the most common age group? In osteosarcoma, it was 15 to 25 years of age. In E-wings, what is the most common age group? Yes, in E-wings it is seen in very small children. So you will see in children between 5 to 15 years of age. What is the most common site? The most common site is diaphysis. And which bone is most commonly involved in case of E-wings? Just like OGS, your femur is the one that is most commonly involved. Now in OGS, you were getting fever of pain, swelling, tenderness. What is this symptoms that you see in this? Yes, fever, pain, and tenderness. Same symptoms. But how will you identify if there is a swelling or a tenderness? How will you identify that this is osteogenic sarcoma versus E-wing sarcoma? Clinically, tell me. Clinically, patient has come to you with a swelling and tenderness. So how will you identify? Clinically, not radiologically. Femur में ही है. You're palpating it, you're getting the tenderness, you're feeling that it is warm. Patient is feverish. How will you know what is the tumor? From the site, correct? So your OGS was mainly in the lower end of the femur, and this is in the shaft of the femur. So if you see the swelling in the shaft of the femur, that means it is E-wings. If you see the swelling in the lower end of the femur, that means it is osteogenic sarcoma. Okay. What is the characteristic feature that you see on X-ray? Onion peel appearance, very good. So you can see this lamellated appearance. Okay, so this is called as onion peel appearance. Okay, and you see specific type of rosettes that are present when you take a microscopic, when you take a little part of the tumor and you look at it under microscopy, you see presence of some rosettes. What are those rosettes? They are not flexnointestinal rosettes. Yes, they are Homer-right rosettes. Okay, you see Homer-right rosettes in this case. Okay, now if you're getting fever, pain and tenderness, what could be your most common differential diagnosis in this case? Osteomyelitis, very good. And what is the treatment? Treatment? For OGS, we saw that it was a radio-resistant tumor. Radiation was not working in that place. So in this, you will give chemo. Can you give radiation? Here, it is radio sensitive. Very good. So you give chemo, you give radiation, and you do surgery for excision of the tumor. Okay. All right. Now let's go on to the next part, that is osteomyelitis, because we are seeing that the most common differential diagnosis is osteomyelitis. So what is the most common cause overall? Most common bacteria causing osteomyelitis? Yes, it is Staph aureus. And in IV drug abusers, what is the most common organism? They ask this question many a times. In IV drug abusers, in sickle cell anemia, in animal bite, in human bite, what are the most common organisms? Yes, very good. In IV drug abusers, it is Pseudomonas. In sickle cell anemia patients? No, Staph epidermidis, no. Staph aureus is the one that is causing osteomyelitis. In sickle cell anemia patients, they get Salmonella osteomyelitis. In animal bite, these are very specific ones. Pasteurella, and in human bite, Kigella, Echinella kigella. Okay, very good. What is the most common route of spread of infection in case of osteomyelitis? Hematogenous, yes, and it is the fastest. And amongst the diaphysis, epiphysis, metaphysis, what is the most common site that is involved in osteomyelitis and why? Metaphysis, very good. Why, Tariq? Why is the metaphysis most commonly involved in osteomyelitis? Why exactly the metaphysis? Yes, because your metaphysis is very vascular, that is the first thing, and your metaphysis has these hairpin loop bend, so it has very bent vessels. Okay, so because of this hairpin loop bend, what happens? The blood flow over here in this area is very sluggish, so the blood will get collected over here, and if the blood gets collected over here, the bacteria can grow more and more and cause infection. Okay, so it is presence of very vascular metaphysis and hairpin loop bend. Okay, all right. Now, your osteomyelitis can be classified on the basis of duration of symptoms. So, into acute, subacute, and chronic. So, when do you call something acute osteomyelitis? Thank you, Bean. I have actually put it because I went for a friend's mehndi. Okay. So, when do we diagnose it as acute osteomyelitis? What is the duration for which you have to call it as acute osteomyelitis? So it should be less than 2 weeks. Okay, what is the duration for subacute osteomyelitis? For subacute osteomyelitis, 2 to 4 weeks, very good. And for chronic osteomyelitis, more than 4 weeks. Okay, all right. What is the most sensitive investigation in case of osteomyelitis? It will tell you within 6 hours only of the infection happening that there is some kind of inflammation and there is some kind of swelling over there. Yes, very good. So your MRI scan can tell you within 6 hours of onset of infection that there is presence of some inflammation and swelling over there. Okay, and if you do a technetium 99 scan in case of osteomyelitis, what will happen in technetium 99 scan? Do you have normal activity, reduced activity, increased activity, altered activity? What do you have? Very good, weapon. So you have increased activity. No, in technetium 99 scan you will have increased uptake of the technetium. Okay, now remember technetium 99 scan, basically the cells that are metabolically active in the body, okay, they will take up technetium. So what happens in case of any kind of infection? The cells become hyper. They start, the immune cells come to that place. There are so many inflammatory markers. Then all the cells start acting like the metabolically active. So they start taking up more and more of the technetium. So you will have increased uptake of technetium in this case. Okay. Then on X-ray you can see loss of soft tissue planes. That is the first sign that you can see, and then later on you will see periosteal reaction. Okay. Alright. Now in osteomyelitis, can you tell me what happens to the ESR, procalcitonin and CRP? What will happen to these three values? Is there any specific pattern of these values? All of them will increase, or one will increase and the rest won't increase? Okay. Now all of them will increase, that is correct. Your ESR and CRP will just tell you that there is an infection. Can anyone tell me what is PCT? What is PCT? PCT is procalcitonin. Okay, your procalcitonin levels will rise whenever you have a bacterial infection. So if they are saying that your procalcitonin levels have increased, that means you have a bacterial infection. Okay, all right. So that means you can rule out viral and fungal infection in that case. Any infection in the body that is bacterial in nature will cause a rise in procalcitonin levels. Okay, so you will know कभी antibiotic देना है और कभी antibiotic नहीं देना है. What is the most common complication of acute osteomyelitis? Most common complication of acute osteomyelitis? Yes, it becomes chronic if you don't treat it. It becomes chronic and it causes destruction of the bone. Okay, now very important question. I'll mark it as star over here. What is sequestrum and what is involucrum? What is sequestrum and what is involucrum? Bolo, what is sequestrum? What is involucrum? No. In osteomyelitis, the bacteria will grow and it will destroy the bone, correct? So the destroyed bone is called as sequestrum. Destroyed or dead bone is called as sequestrum. And what is involucrum? So once this bone is destroyed, there will be an inflammatory reaction and there will be formation of new bone. Okay. So the immature new bone formation is called as involucrum. Okay, so these are two terms that they ask many times in the exam, so you should be aware. You should definitely know this. Sequestrum, so they have asked many times. Many of you all get confused between it. So just remember, sequestrum is dead bone and involucrum is immature bone. How will you remember this? I for involucrum and I for immature newborn. Okay. What is the treatment of acute osteomyelitis? It is price. Anyone, what is price? What is the full form of price? Yes, IV antibiotics, so you have to give. But other than that, what is all the features of price? What is P? P is pain relief. It's very, very painful, tender, so you have to give analgesics. What is R? R is rest. I is ice or immobilization. What is S? It's very similar to treatment of a undisplaced fracture actually. C is cold pack and E is elevation. Okay. So just like treatment of fracture, you can use this price formula for treatment of osteomyelitis also. And the mainstay of treatment will always be antibiotics. Okay. And guys, remember, bones getting infected are really bad because once the bone starts getting destroyed, there is no going back. You will have bone loss. Patient will also stop moving. He can't even walk. Stiffness is there. It's very, very difficult to eradicate a infection from a bone. Okay. All right. Okay. What is Brody's abscess and what is Gar's sclerosing osteomyelitis? This is also something that they ask. What is Brody's abscess? Subacute osteomyelitis. In which part of the bone? Which bone? In which bone do you get this? It's not chronic. Chronic is more than 4 weeks. The duration for Brody's is 2 to 4 weeks. Yes, very good. So in tibia, when you're getting acute osteomyelitis, it is called as Brody's abscess. Okay, what is Gar's sclerosing osteomyelitis? Is this acute, subacute, or chronic osteomyelitis? And where? Okay, so chronic osteomyelitis, more than 4 week old, of the mandible. Okay, of the mandible. So these two also they ask many times in the exam. Brody's abscess is in the tibia and Gar's is in the mandible. Okay, all right. Moving on to our osteoarthritis. So everyone knows osteoarthritis. What is the typical age group in which you will see osteoarthritis and typical kind of risk factor for developing osteoarthritis? Very good. Old age is the strongest risk factor. What is the other important risk factor? Menopause, not really. Menopause is for osteoporosis. For osteoarthritis, मोटे मोटे लोग जो होते हैं, obesity, okay, because you tend to put a lot of pressure on your joints. Okay, yeah. What is the most common joint involved in case of osteoarthritis? You're having continuous wear and tear of the joints. So what is the most common joint on which most of our weight bearing is there? Most common joint. Are weight bearing is on distal interphalangeal? Yes, it is knee joint. Okay. Knee joint is the weight bearing joint of our body and it is the most common to get osteoarthritis, and because of this, total knee replacement is the treatment of it. Okay, once the bone gets destroyed, the joint gets destroyed because of osteoarthritis, they do a total knee replacement. Okay, what is the most common bone that is affected in the knee joint also? इधर ही नीचे आंसर लिखा था. Out of patella, lower end of femur and upper end of tibia, which is the most common bone that undergoes wear and tear in the knee? It is patella. Very good. And what is the joint that is spared overall in the body? Which is the joint which will never undergo osteoarthritis? Wrist, very good. Your metacarpophalangeal joints. Okay, your metacarpophalangeal joints will are spared in case of osteoarthritis. ये पूछते हैं exam में, so please you should know this. Okay, all right. Now, what is the earliest symptom of osteoarthritis? Suppose I start developing osteoarthritis. What is the first thing that I will have? Any of you all are looking at my hands and coming up with some answers. What is the earliest symptom of osteoarthritis? Stiffness. No. Early morning stiffness is not seen in osteoarthritis. Early morning finger stiffness is seen in which case? It is seen in case of rheumatoid arthritis, correct? So in osteoarthritis, since the knee joint is most commonly involved, you will have pain on mobilization. That's why they will not be able to walk, they will not be able to carry out normal activities. That is why they have to go in for early surgery. Okay. Other than that, you also get some swelling, you also get some tenderness, and you start getting deformity also. Okay. It is called as varus deformity of the knees. Okay. Bouchard's nodes and Hubbard's nodes, you guys have already seen the picture. Bouchard's nodes is seen on proximal interphalangeal joint and your Hubbard's nodes is seen on distal interphalangeal joint. On X-ray, what is the first or the earliest sign that you see? This is your Bouchard's and Hubbard's nodes. Bouchard's nodes in proximal interphalangeal and Hubbard's nodes in distal interphalangeal. Okay, these are all the radiological signs that you will see. You will see this presence of osteophytes. Okay, what is osteophytes? This is new bone that is formed, new sharp bone because of continuous wear and tear, and you will see sclerosis of the opposing surfaces of the joint and reduced joint space. So, what is the first sign to see out of all of these? Yes. So, the earliest sign is reduction of joint space. Earliest sign is reduction of joint space. Okay? Okay. Treatment of osteoarthritis, they will have pain on mobilization, so give painkillers, give physiotherapy to make the ligament stronger. Your ACL and PCL should be made stronger. You can give viscosupplementation, that is nothing but sort of a jelly or a cushioning effect. So here you can give it so that there is not much wear and tear of the joints and there is good amount of lubrication for the joints, but that is just a temporary treatment. And surgically, what is the treatment that we prefer? Total knee replacement. Okay. Eventually, most of them have to go in for total knee replacement only. Then you have other drugs like diacerin, chondroitin sulfate. All of these again are lubricating for the joint. Okay. Next, we have rheumatoid arthritis. So, rheumatoid arthritis is nothing but a what kind of disease? Inflammatory synovitis, correct? So this is an autoimmune disease. So you have antibodies developing against the synovial lining of the joint. So as a result of this, the synovial lining becomes inflamed and it stops producing synovial fluid. So it is usually seen in women way more than in men between 40 to 60 years of age. What is the most common joint affected in rheumatoid arthritis? Yes, your metacarpophalangeal joint is the most common joint affected, and then after that is your proximal interphalangeal joint and then spine. So if MCP is the most common joint affected, what will be the earliest sign or symptom in case of rheumatoid arthritis? What will the person come with? I told you, yes, he will have early morning stiffness. And as the day progresses, the stiffness will get better. Okay, so early morning stiffness is the first symptom to appear. Okay, on diagnosis, obviously you will check for your anti-CCP, anti-ROLA antibodies, rheumatoid factor, all of those things, anti-Smith antibodies, all of those that I've taught you in medicine. Okay, now what is this appearance that I told you? This one was swan neck deformity. Okay, so what are you getting in swan neck deformity? You're getting flexion of this proximal interphalangeal joint and extension of the distal interphalangeal joint. That is your swan neck deformity. Now, can you tell me what is this deformity? There is right angle at the level of the proximal interphalangeal joint. This is not Z deformity. This complete right angle of flexion at the level of proximal interphalangeal joint. Yes, very good, Tariq. So this is called as your boutonniere deformity. This is your boutonniere deformity. Okay. There is just one small problem over here. You're actually getting flexion over here at the proximal interphalangeal joint. I mistakenly marked it there, and you're getting extension over here at the distal interphalangeal joint. Okay, so that is why you're getting the PIP and DIP involvement causing boot and deformity. Okay, now what is this deviation called as? This is called as Z deviation. Okay, Z deviation, or the deviation of the hand towards the ulnar area. So this is called as ulnar deviation or Z deviation of the hands. Okay, all right. So all these three things, na rheumatoid arthritis के बारे में in ortho they ask you mostly this only. Z deviation, swan neck deformity, boot and neck deformity, all these are seen in which disease? So simply you just have to answer it is seen in case of rheumatoid arthritis. Okay. So for diagnosing rheumatoid arthritis, 4 out of the following 7 criteria should be present. First thing is morning stiffness. Then is arthritis of more than 3 joint areas. So you should have MCP, PIP, DIP, more than 3 joints should be involved. Hand joint should be involved for sure. There should be symmetric arthritis. Both hands should be having it. If one side is having it, means it could be osteoarthritis. If both sides is having, means it is an inflammatory disorder. So rheumatoid arthritis. Rheumatoid nodules should be present. There are subcutaneous nodules that are present. Serum rheumatoid factor should be high, and X-ray changes should be present. Okay. So how to remember this? Now during my UG, I used to use a very nice way to remember this. So I used to just simply make sure that I imagine a person who's coming to me with morning stiffness. Okay, so imagine you're waking up in the morning and you see your hands have become extremely stiff. So you have morning stiffness. Then you try to walk and you're not able to walk also. Why? Because your knees are also stiff. And when you do this, you move your neck in the morning, you're trying to stretch your neck, that is also not moving, so there is involvement of more than 3 joints. Okay, now the hands were not moving, so there is involvement of hand joints. Both hands are involved, so it is symmetric arthritis. Then you start looking essay, ki what is wrong with me, what is wrong with me? Then you see presence of rheumatoid nodules also. So you go immediately to the doctor and you get your levels checked. So you see that your serum rheumatoid factor levels are very high, and then he asks you to do an X-ray where you see that you have all these changes: swan neck deformity, Z deviation, and boot and deformity. Okay, so that's how you can remember the 7 criteria of rheumatoid arthritis. Clear? Okay. Now, seronegative spondyloarthropathy, that I have already covered in all these kinds of arthritis, and arthropathies. I've actually covered very nicely and in detail in case of there was one class of medicine rheumatology that I have taken on special class platform only. So it's freely available for all of you all. You all can watch that and you'll be able to answer all the questions once you see it. Because I know all of these become very confusing for you guys. Osteoarthritis, rheumatoid arthritis, kya kidhar kya hai, seronegative spondyloarthropathy. Eventually, you all are doing all 19 subjects, so everything gets confusing and you're like, abhi kya answer karna hai. So just go through that class once, watch it at 1.5x the speed, and you'll be able to answer the differences between all of them. Okay. Alright. So last question for today, I think, identify the condition in this case: dorsolumbar hemangioma, osteochondroma, epidural abscess, or port spine. Okay, very good. So if you all had come for my previous class, 100% of you would have been getting this. What is this appearance of the abscess called as? First of all, it is present in the lower thoracic and the upper lumbar areas. So this is your dorsolumbar spine, correct? And what is this destruction of the vertebral bodies and the abscess spreading on the sides called as? This is called as fusiform appearance of the abscess. Or it also looks like bird's nest appearance of the abscess. Okay. So this is seen in case of port spine. And which kind of port spine does it spread in? Central you have all these types of port spine: paradiscal, central, anterior, or posterior. So this kind of abscess is seen in case of paradiscal type, which is the most common type of spread of port spine. Okay, all right. So just to revise, what was the most common symptom of port spine? I did it with you guys in the last class. Most common symptom of port spine: back pain. Yes. What is the first clinical sign of port spine? Back stiffness. Yes. And why is that back stiffness happening in case of port spine? It's because of involvement of what muscles? Because your paraspinal muscles get involved in the inflammation. Okay. Okay, what is a gibbous, kyphus and knuckle? So knuckle is when one vertebral body is destroyed. Then you have gibbous when two vertebral bodies are destroyed, and you have a kyphus when more than two vertebral bodies are destroyed. Three, or you can also call it as three or more than three. Okay. And cold abscess is the abscess that is formed by destruction of the vertebral bodies, because you have no signs of inflammation, no fever, no nothing. Okay. All right. So that's it for our orthopedic revision. I hope you guys enjoyed the class. Are there any doubts that you guys want to ask me? I know I have not covered fractures and trauma and everything in orthopedics. Uh, but I think most of it, like 60-70% of orthopedics has been covered. We have done all types of tumors, we have done all types of arthritis, we have done port spine, which is one of the most important things that is asked in the exam. We have done some important kind of fractures, malunion, non-union, and mostly a lot of image-based questions come in orthopedics. Okay, so I think that this was useful for you guys. Now tomorrow I'm having, I'll tell you over here. So tomorrow at 11 a.m. we'll start off at 11 a.m. and 1 p.m. Okay, we'll have radiology part 1. Now these will be very fun classes, because I'm going to put direct questions from FMGE exams that were asked about radiology with options and everything. Okay, so radiology part 1 and radiology part 2. So all the x-rays, CT scans, USGs questions that are asked in your exam from radiology, I'll directly put it for you all to revise. Okay, and what is pylon fracture? Okay, does anyone know what is pylon fracture? Rohit is asking. Okay, so 11 a.m. we'll be having radiology part 1. 1 p.m. we will be having radiology part 2. Okay, and after that we will be having in the evening at 5 p.m. I'm keeping a special class for you guys to know what is anesthesia exactly. Many of you all are NEET PG aspirants who now want to take your branch. Okay, so you all have this what is this counseling going on. So many of you all are asking many questions on the group about what colleges to take, what is the life after anesthesia, what is the life for freelancing, what is the life for corporate hospitals, government hospitals, all of that. So I'll be taking a special class in which I will be answering all of these questions tomorrow at 5 p.m. So hopefully I will see now your FMG students. I know that maybe this might not be useful for you all at this point in time, but definitely I can tell you that aage jaake for your branch selection, whenever you give NEET PG, this will be useful. So don't hesitate. If you guys have the time, come and join it and we'll be able to answer it. Okay. Yes, Tariq has absolutely correctly mentioned distal tibia intra-articular fracture is called as pylon fracture. Okay. All right. Anyone, any other doubts, or should we conclude for today? Saturday night, maybe you guys should live it out and start enjoying now. Okay. So let's wrap up with our class for today, and I shall see you guys tomorrow. Till then, take care and keep studying. Bye bye.